Thank you all for being here, of course. Welcome to the 34th FD Day. As you know, the first Sunday of June of every year for 34 years, the FD community meets to see each other. Many people only see each other today, and also to hear news and what's going on at the center. You heard, and you have the programs. We have a packed program today, and we have some excellent speakers in the morning. I'll tell you about in a second, and then we have a panel of experts in the afternoon. So, the first order of business, as you know, is the population statistics, right? That's what I speak every year, and I tell you what's new. So this year, don't be afraid. I'm not starting. It's going to be fast, but I want to remind you that. Let's see, is this here? I want to remind you that the FD mutation actually originated in Poland, on an area that is now Poland, in the 1600s, right? In the 1500s, actually in the 16th century. Now, this is important because, as you are aware, and as Sue discovered, everybody that has this mutation, this T2C change in the IK-BCAP gene, is a descendant of one person that's called the founder. So everybody that has FD is a descendant of one person that had a mutation in the 1500s. Now, how did that happen? Now, well, it happened in part, at least in big part, thanks to Catherine the Great. You know, Catherine II, the Emperor of Russia, in 1791, after the partition of Poland, she declared that all Jews were legally restricted within an area that is roughly the western part of Russia, Lithuania, and Poland, so between the Baltic Sea and the Black Sea. Now, although initially the number of Jews there was quite small, and in fact, since the end of the Roman Empire, in the next 1,000 years, from a few million, or actually for maybe 6 million Jews, they went as down as probably a few thousand that settled in that area that is now Poland. Now, interestingly, although things were quite bad, Jews fared quite well in the Pale of Settlement. This I got this from Haaretz, from this Israeli newspaper, in which they have these days in Jewish history, and they said, well, December 23rd, 1791, was the day that Catherine the Great told Jews where they can live and restrict their movements. Why I'm telling you this story? I'm telling you the story because although the population had contracted dramatically in the next 150 years or 200 years until the 1900s, from 12,000, actually the population went to 5 million, close to 5 million Jews. Now, this is 150 times increase, and of course, they were only living in that area, so they only married people they knew, and essentially everybody married inside the family. So in 150 years, 5 million people, and so what happened? Let me show you in this map. On the left side, it's just to locate you where the Baltic Sea and the Black Sea is, and on the left side, you have the area, the exact area of the Pale, and the percentages show you there what was the percent of Jews within the Pale of settlement before the different areas. You see that in some areas, close to 20% of the population in some areas of the Pale were Jews. So the number was quite big. This is a map also from the time showing that over 5 million people, 5 million Jews lived in Russia, divided and most of them, close to 5 million, in the Pale of Settlement. Now, life in the Pale was not that great. Was very good for some, but was not that good for others. And in fact, it got quite congested because almost 1 million people from the countryside, 1 million Jews from the countryside were obliged to go inside the Pale. So things got quite complicated, and a lot of guys by the 1880 decided that they were out of there and they were going to leave. And so they did. This map shows how in around 1880, if you see it here, mostly from the city of Brody at the western side of the Pale, started the migration, the exodus from the Pale that took over 2 million Jews to the United States, Britain, Europe, South America, and Israel. Now, interestingly, if you look at from the area of the Pale of Settlement to the emigration, you see that over 2 million Jews from the Pale moved to the US, around 115,000 to Argentina, some to South Africa, 45,000 to Australia, 65,000 to Israel, almost 150,000 to the UK. Now, why I'm telling you these numbers? I'm telling you these numbers because, interestingly, the percent of patients in the database of the center, all our patients with FD, the percent from every country corresponds almost perfectly with the emigration from the Pale. So if you see the 54% of people that emigrated from the Pale went to the US, and that's exactly the number of patients with FD living in the US. 4% in Canada, 2% in South America, 1% in South Africa, Australia, and 32% in Israel. Now, as you see here, as I was telling you, our population distribution closely matches the migration statistics with the biggest concentrations in the countries I showed you. Now, these that was sort of quite clear started to change, and we think is going to change more, and I'm going to tell you why. In 2015, you may remember, we reported the first patient, and they are here today, I just saw that they are here, a young girl from Mexico, Diana Esparza, and there was something different about her. What was different? Her parents are from central Mexico. She was diagnosed at age 4. She's now living in California, and they have no known Jewish ancestors, neither the father nor the mother. But the whole genome analysis showed that they have 2 copies of the founder mutation. So they didn't know about the Jewish ancestry, but not only they have it, it comes from both sides. Now, at that time, we wonder, 4 years ago, how did both parents, and again, you will meet them here, how did they come to carry that founder mutation? Now, are there going to be more cases? And we'll talk in a minute how they could have gotten it, but are there going to be more cases? Lo and behold, there were more cases, and in 2017, Camila, another beautiful little girl who's the cousin of Diana, and she's living in Mexico, was also diagnosed with FD with 2 copies of the founder mutation. So let me go from there to this year's statistics, and I tell you why. So in this year, from 2018 to 2019, we have 3 new FD patients. Now, the 3 of them are girls. We are lucky. There's a 13-year-old girl, a 3-year-old girl, and a 10-month-old girl whom we heard only 10 days ago. Now, the first 2 girls are from Mexico, not from Aguascalientes, not the area where Esparza is, but closer to the capital, to Mexico City. So both girls. And the third girl, the 10 months old, is in Kassel in Germany. Now, there's something quite interesting, and now is not that striking, about these 3 girls. The 6 parents, mothers and parents of these young girls, all of them are unaware, none of the patients were aware of Jewish heritage, And you see, from the parents in Germany, it's somewhat understandable. They are from Eastern Europe. We found out they are from Eastern Europe, and they are unaware of Jewish links. But they come from an area with a very high prevalence of maybe 1 in 18 Jews in Poland, and in the general population less, but it's there with carriers of the gene. But the patients from Mexico, they trace their grandparents, at least as far as they know, 3 or 4 generations are having no connection with the Jewish community, and they were baptized. They have no connection. So, in summary, there are now 4 girls with FD from Mexico, right? Now, what are the chances? And perhaps, I pose the question, perhaps somebody from Sue's lab, Gadi, or some of the population geneticists can help us answer this. So what are the chances that 4 young women, the mothers, all unaware of their Jewish heritage, will meet 4 young men, the fathers, in the same situation, who are also the carriers of the gene, and this would happen in Mexico, which is a country of 150 million people, where there are a lot of Jews. There are almost 40,000 Jews, but they are not connected to this community. So how does that happen? How 4 mothers meet 4 parents, all carriers of the gene, all with absolutely no knowledge or no connection with the Jewish community? And I tell you, both of them are descendants of our friend in the 1500 in Poland. They have that mutation. The founder is the ancestor of them, like of any of the other. How, if this is not a hay in the needle stack, I don't know what is. So I think we need, so why this matters? Why I'm telling you this? I think it matters, and I'm throwing you the question, is something we all have to think, because there may be a very large number of undiagnosed patients. And one wonders whether larger genetic screening, rather than the passive genetic screening that we do when a patient gets whole genome or consults, perhaps we should reverse this, and in some areas, we should do more active screening, where perhaps more cases, significantly more cases, would be found. So I leave you with that question. I have a few more minutes. So I will give you the health report also very briefly. I want to tell you that we are keeping FD at bay to the extent we can. The frequency of hypertension and renal complications has decreased substantially with very targeted treatments. We also have aggressive treatment of pulmonary problems, and the patients are admitted less to the hospital. We are using BiPAP and CPAP, assisted ventilation, much more, and we believe this will prolong lives. And there are also new ways of protecting the corneas, and you will hear about that from Dr. Raju in a few minutes, and we believe this will allow maintaining vision. But of course, this is not enough. I know you don't want to hear many details of what we're doing better. You want to know if we have a cure, and that's what we also want. We need a cure. Now, I believe, you've been hearing things, we are getting significantly closer to a cure. Now, why is that? Well, I think we are quite lucky that what initially was just a concept of the possibility of a drug that would modify or correct splicing is getting much closer to reality. And in December 2018, a few months ago, PTC, you heard about PTC already, which is a biotech and pharma company, decided to take up the challenge of developing a drug to treat familial dysautonomia based on the old kinetin that Sue had initially identified. So in December, after with a lot of work and variations, they announced the compound that is there, and they also announced their commitment to bringing it to the clinic. Now, I'm not going to go in this in detail. It's just to remind you something you've seen many times, and is that the splicing mutation in that gene, that in the IKB-cap gene, now called ELP gene, leads to a deficiency of a specific protein, and that deficiency is what produces FD. Now, as you can see here, right, this is the normal way of doing it, and this is the FD way of doing it. Now, if you add this new compound, which is now called PTC258, in mice, you see that the amount of protein, of normal protein that was deficient in patients with FD increases significantly, as you can see here, in a dose-dependent manner. So we hope really to be in the clinic as fast as we can. We are all working feverishly to keep this moving, and to make this successful, we all need to work together. We need to choose and validate what's called outcome measures, and you'll hear Lucy and other speakers talking about today, about specifically what this means. And we also need to complete the natural history study, so we are not going to have to use placebo. So you'll hear about all this today. I want to tell you, be confident that we have Superman here with PTC 258, but more than that, we have all the female doctors, Bhumika and Lucy, from the FD Center, which are ready for action and will make sure that this happens. So we have a big challenge finding accurate ways to measure how the drug works, but we are sure we are going to be able to put all these pieces together. So before, I know I have just a few minutes, I want to briefly end with telling you about new people at the center. Now, you know that everything we do is only as good as the people we have, right? It's not just equipment or the place, it's only the people. So there are some people you met this year. I first want to make certain that you know who Dr. Bhumika Balgovin is. She started her second year as a clinical fellow at the center, and we're very lucky to have her. She has done an extraordinary job. Bhumika already knows every one of you, and she's the one that comes on weekends to make sure that all her patients are well taken care of. And if you met her already, you know not only she's very good medically, she's kind, and she has the patience of a saint. She came highly recommended to us. She had completed the 3-year neurology residency. She was also chief resident at Stony Brook in New York, and she was also there a clinical neurophysiology fellow. So, in fact, during her fellowship is when I met Bhumika for the first time, because she consulted us on a very rare case that she had diagnosed on a patient, on a young girl with a very rare autonomic abnormality that perhaps next year you'll hear about her, not with FD, but with a very rare problem that we were able to solve. She was so fascinated with autonomic that we convinced her to come and work with us, and the rest of history, you've been the lucky ones. The other person I want to introduce is Dr. Maria Cotrina, or Maria Luisa Cotrina. She joined the center also last year in November 2008 as a clinical coordinator and research scientist focusing on the natural history study. She has a PhD in cell biology from New York Medical College, and what's so interesting about Maria or Marisa is that what she was doing at Bellevue, working also for NYU, was she was coordinating the research project for the survivors of the World Trade Center. So collecting all the medical information of people that had been exposed to see if something would happen to them in the future. Well, we thought that FD was a much smaller community, but with the experience of what happened in 9/11, we thought Maria would be fantastic for us, and she has turned out to be excellent. Many of you had met her. She's very interested in the disease, and she also has a son, a terrific kid, who needs a gastrostomy. So in addition to all she knows about science, she knows about gastrostomy feedings in a way that few people I ever met knows exactly how to do it. So we are also using that expertise of Maria, and I encourage you to meet her and talk with her. Finally, I want to announce also another great acquisition, to call it in Hollywood terms, and that's Bar Morgenstern-Hiller. She's a biomedical engineer that just joined us a few days ago. Bar grew up in Israel and completed her undergraduate degree at Tel Aviv University in electrical engineering. So then she moved to New York recently to do a master's in biomedical engineering at NYU. As a biomedical engineer, we are lucky that she got interested in the eye and the retina in familial dysautonomia, which of course this is crucial for the development of outcome measures, and you'll hear more today. About it. She will be spearheading that project and doing all the engineering part that is necessary to analyze this data. I also have to tell you that Bar completed her military service in Israel, but the only thing she would say is that she was in intelligence. I think if you ask her anything more, she has to kill you, so don't ask her anything exactly about what she was doing on the military service. So thank you very much. I think I'm on time, Natasha, right?